And our first speaker is Peter Rees. And Peter is Professor of Medicine at the Academic Medical Centre in Amsterdam and was recently appointed Director of the Netherlands HIV Monitoring Foundation. He's the immediate past President of the European AIDS Clinical Society and is a regional representative for Europe and Central Asia on the IAS Governing Council. Please welcome Peter Rees.
Thank you very much, Rob, for the kind introduction, and thank you all for coming to this session. As you can see, I've been given quite a challenging title by the conveners, and I hope to share my thoughts about these topics with you in the next 15 minutes or so. These are my disclosures. So why is there a need to disentangle these issues? And this picture shows you data of a study that we're conducting in Amsterdam, where we're comparing a cohort of people with HIV, mostly under treatment and suppressive treatment, with a cohort of people who are uninfected. And what you can see from the baseline assessment of this study, which will soon be published, is that across the board, the prevalence of a wide range of comorbidities is higher in those with HIV. Not all reach statistical significance at this stage, but the pattern is quite striking, and it varies from cardiovascular disease across the board to renal dysfunction, etc. What we also found in this study is, and if you look at the black squares that are highlighted on the slide, is that especially the prevalence of multimorbidity, so people having 3 or more comorbidities at the same time, is strikingly higher, especially in those individuals who are 60 years or 65 years and older. And of course, that number is still quite limited in our cohort, but as we go along, it will rise, and it's certainly a concern for the future. Another reason to disentangle these issues is that probably what is driving this higher prevalence of comorbidity is multifactorial. And I think we can't stress enough the importance of lifestyle-related factors, and some of which we can obviously do something about. Another issue which is getting a lot of attention, and is probably very important, is persistent immune dysregulation and inflammation, even in people with well-treated HIV disease. And although ART toxicity has moved a little bit to the background, I think it's something that for the long term we still need to pay attention on, because there may be things in there that we still don't know about. And all of these factors act together against the background of simply natural, normal aging, and leads to an increased risk of clinical chronic comorbidity. Now, in the study that we're conducting in Amsterdam, at baseline, when people entered the cohort, we've looked at the factors that we found to be independently associated with having a higher number of comorbidity. And as you can see from the slide, the traditional, as expected, traditional known risk factors play an important role. But in addition, what stood out is that HIV, being HIV infected, yes or no, was not associated, but what was associated is the duration of immunodeficiency. So having had a longer duration of a CD4 cell count below 200 was associated with increased risk. And also we found some evidence for markers of especially innate immune activation to be associated. And the other factor that came out was a longer duration of exposure to high-dose ritonavir, the doses that we don't use currently in our regimens, but which we did use at the time that protease inhibitors first became available, including ritonavir being used as therapy on its own in a high dose. So let's talk a little bit about lifestyle-related risk factors, because as I said, I think we still need to make sure that these remain center stage in our thinking about these issues. So this is just one example of a study from Denmark in the Danish HIV cohort study that that actually nicely illustrates the importance of smoking, because in a setting like Denmark, where HIV care is extremely well organized, antiretroviral therapy is provided free of charge, HIV-infected smokers lose more life years to smoking than to HIV. So obviously, from a public health perspective, addressing an issue such as smoking is going to be extremely important. Another study, this is from Steve Grinspoon's group in Boston at the Mass General Hospital, where they looked at carotid intermedia thickness. They found that especially in the people who had the highest rates of smoking, shown on the left, let me see if I can, I never like to use the pointer, but see if it works. Doesn't seem to work. Anyway, it's the bars for you on the left-hand side of the slide. You can see that especially in those over age 50, in the dark blue bars, you see that the effect of smoking in those with HIV on carotid IMT seems to be accentuated. So smoking may have a higher impact on the cardiovascular system in those with HIV. The other issue is our toxicity, and of course we know that there are, I just listed some examples, but we all know about the potential effects of protease inhibitors, some more than others, and possibly abacavir on the cardiovascular system. We know about tenofovir and its effects on the kidney and on bone. And of course we've been using these drugs for quite a long time, but people will be using them much longer, and we'll have to follow what the effects of the even more prolonged use of these agents is on these organ systems, and they may therefore obviously also contribute to certain of the comorbidities that we're talking about today. Now, the background, of course, is normal aging, and aging is by far the strongest risk factor for all of these conditions. It's characterized by a progressive loss, as we unfortunately all experience, of physiological integrity, leading to impaired function and increased vulnerability to death. And it's that deterioration which is really the primary risk factor for many of the pathologies, including cancer, diabetes, cardiovascular disease, and neurodegenerative disorders that are increased with aging. Now, in the context of HIV, as you know, there is a debate ongoing whether these age-related conditions are simply accentuated, which would be bad enough, or also accelerated. Now, in the case of an accentuated risk, the condition occurs at the same age, but more often in those with HIV than in HIV-uninfected controls. If there is also an accelerated risk, these conditions are not only more prevalent, but they would also occur at a younger age. So in that sense, it's important to try and study the interaction between normal aging in the context, or the interaction with aging in the context with HIV. And I'll talk a little bit about that. Now, if one wants to study that, of course, one needs to go to the literature on aging and how the aging field and aging research field thinks about aging. And for those who are interested, I would really recommend you to read the article referenced on the bottom of this slide, because it's a beautiful review of the concepts in general aging research that are out there. And the way the authors build up their paper is that they indicate that there's a number of different mechanisms which are likely the initiating triggers whose damaging consequences progressively accumulate over time. There are also a number of conditions which in principle in the beginning are beneficial and really antagonize the primary causes of damage, but then progressively actually start to act in concert and produce more damage. And then finally, there are a number of mechanisms which act as sort of final common pathways and eventually lead to biological aging. Now, if you look at each of these 9 hallmarks, it is striking that if you dive into the literature, and you should realize that many of these are in vitro studies, but in fact, if you go to many of these conditions, you'll find that HIV, and to some extent also in certain situations, specific antiretrovirals, may be affecting these different mechanisms. And I have some examples from the literature here. I pulled out some examples actually of work done in Australia and also particularly in Melbourne concerning, for instance, the inhibition of telomerase activity by different antiretrovirals. There is evidence here from Susan Crow's group on accelerated aging of the innate immune system. There are also evidence from France about certain protease inhibitors leading to the accumulation of prelamin A. And there's also older work from Australia about HIV protease inhibitors inhibiting the proteasome. And each of these features are different hallmarks of biological aging. So I think we need to keep an open mind that some of the drugs that we are using may affect these mechanisms, although we know very little about what that would mean in different tissues of the body and what it would mean long term. But it's something to keep in the back of our minds. Now, if we put that all together, the picture that seems to be emerging, even in the context of patients with well-treated HIV infection, is that there is persistent immune dysregulation, that there is persistent defects in gut epithelial integrity leading to persistent microbial translocation, and all of these in concert with persistent co-infections like CMV and activity from CMV and possibly also residual activity of HIV lead to persistent low-grade immune activation and inflammation, which is strongly again associated with fibrosis in tissue and coagulation activation. And inflammation, if you look at the aging literature, is strongly associated with aging of the immune system, which again then reinforces immune dysregulation, but it could also be associated with aging of other cells and tissues, and we know that aging cells and tissues again reinforce inflammation, thereby building a sort of reinforcing loop. And clinically, this could promote the expression and the occurrence of chronic aging-associated comorbidity and frailty. And as I said, and as I indicated in my previous slide, and I put a question mark there simply because not enough research has been done and we don't know enough, ART itself and specific antiretrovirals over the long term may also be exerting an influence. So, does HIV and or ART affect comorbidity risks by effects on biological aging in people living with HIV? I think it's an interesting concept in view of the higher incidence of a range of aging-associated diseases and the presence of plausible mechanisms. However, and I think this needs to be stressed, at this stage it remains hypothetical, and the hypothesis either needs to be proven or hopefully refuted. In order to study that, I think we will need reliable markers of biological age, which we need then to apply to appropriately designed longitudinal clinical studies. And in addition, and of course there's always the difficulty with animal models, but animal models may potentially provide a way to get more insight in distinguishing the effects of HIV infection per se from those of antiretroviral treatment. And this is something that in our group we're trying to address in a program which is funded by the European Commission called COBRA, in which we, in a very multifactorial way and by eliciting the help of scientists from different fields, HIV, but also aging, try to look both in clinical cohort studies as well as in a humanized immune mouse system model whether we can disentangle these different factors better. But this is a program that has started about a year ago and still needs time to yield results. So in summary, I think many studies have shown that the burden of various comorbidities are consistently increased in HIV. I think traditional risk factors play an extremely important role, and this needs to be reflected in our clinical management and care. Independent associations with HIV are observed for some, but not all of the comorbidities. So that means that we should be very careful to generalize and make sure that we study each of these diseases, not only in concert, but also individually. I think what is coming out of our analysis, but also of many other analyses, is that immunodeficiency and a longer time of exposure to immunodeficiency is not good, and that including in our own studies and analyses, that it's not so much longer exposure to ART, and certainly not the current regimens, but it's more the immunodeficiency that generally contributes to greater comorbidity risk, which provides, of course, an important argument for earlier treatment. Persistent inflammation and innate immune activation, I think it's more the innate immune system than the specific immune system, generally seems to contribute towards risk, although again our analyses show that this may differ for different conditions. And with respect to biological aging, I think the pathogenic pathways that involve possible effects on the biology of aging simply haven't been explored yet and need further study. Now, I think it's also very important to put this in a global perspective, and this is a picture or a slide that I got from someone at a recent WHO meeting in Geneva on this topic of HIV and comorbidity. And it shows the map of the world with the 4 main NCDs: cardiovascular disease, cancer, diabetes, and chronic respiratory disease. And it'll be immediately clear to you that the distribution of these diseases very much overlaps with the focal points of the HIV epidemic in the world. And therefore, studying these issues also in the setting, in more resource-limited settings, and I'm sure Wafa will talk about that, is very important. So finally, and particularly in this last week, I'd like to use a slide and a quote from Judy Currier, which she used at the AIDS 2012 World AIDS Conference. "Do not regret growing older. It is a privilege denied to many." And I'd like to acknowledge all the people in my team, but particularly our study participants, our funders, number of friends and colleagues across the world that I'm fortunate to have as friends and colleagues and be able to discuss these issues with. And I've left this for the last slide because I knew I wouldn't be able to get through the talk if I showed you this slide in the beginning. These are my colleagues and close friends of over 35 and 40 years respectively, Joep Lange and Jacqueline van Tongeren, who perished on last week on the Malaysian Airlines flight. I will miss them dearly. The photograph is taken by a patient of Joep's who he didn't do much clinical work anymore, but she was one of the few people that he was still taking care of. She's a photographer, and she took these pictures recently, and I asked her permission whether I could show them, and she said, "Oh yes, please do. I'll send you the black and whites because they're much better than the color versions." So she did, and she also in her email said to me, "Listen, if it weren't for Joep, I wouldn't be able to send you these photographs and I wouldn't be alive." So with that, I thank you for your attention.
Thank you very much, Peter, and thank you very much again for the tribute to Joep and Jacqueline.